And good afternoon or good evening, wherever you are. It's 7 p.m., just over 7 p.m. in Karachi, and I think it's about 4 p.m. In Birmingham. So we're going to talk about minimally invasive treatment for benign prostatic hyperplasia today. And we are very fortunate to have Mr. Ananda Dhanasekaran. As you know, that conceptual basis of urology is a bi-monthly course, and we have every first and third Saturday of the month, 7 p.m. Pakistan time, we have invited speakers from all around the world, and we are very fortunate today to have Mr. Dhanasekaran. He's a very good friend now, and he has been a great supporter of academic activities in Karachi. Just for those who don't know him, and there should be very few of you now, Mr. Ananda Dhanasekaran is a urology consultant in Sandwell and West Birmingham NHS Trust Hospital. More importantly, he's a NICE guideline lead for the trust, and he's also clinical effectiveness and governance lead for urology. Mr. Dhanasekaran has a great interest in teaching, and that's why he's here on a Saturday afternoon with an interest in endourology, and in particularly in minimally invasive treatments of BPE. So without any further ado, I will request Mr. Dhanasekaran to start off patient. Thank you, Ananda, to be here this afternoon.
Thank you, Professor Amadkar. That's very kind of you. Thanks for the introduction. I will share my screen and take the proceedings. So this is not just the minimally invasive treatment for the BPH. I am also going to discuss only the newer innovations. It is very important, not only for the practicing urologist, it's also good for the students and postgraduates who are preparing for the exams to know these newer modalities. I'm aware that the newer modalities which I'm going to discuss were not yet available in most of the Asian countries, but I'm sure time will come, these energy sources and techniques will be available all over the world. I'm going to discuss 3 energy sources or 3 different methods. All the 3 are quite new for the people in Pakistan and also most of the Asian countries, of which UroLift and Resume are very popular. At least you may be coming across it in the European meetings or American meetings. And we do perform these procedures quite frequently and regularly in United Kingdom. UroLift and Resume are well established. There were multiple guidelines, both AUA guidelines and European guidelines, and we have our own NICE guidelines also. In the end, I will also mention about another evolving technique known as iTint, and based upon the time, we will try to see the technique, how it works, what is the science behind the technique, and how someone who is interested can learn this. I will also try to show some videos so that you can understand the main purpose and physiology of this meeting completely. So first we'll start with UroLift. In the UroLift, we will be discussing for maybe 20 minutes or 25 minutes. We will discuss how will we select the patients, how are we going to screen the patients, what are all the components of UroLift and how the mechanism works, and what is the anesthesia and how we can procedure planning. It is used for treatment of the benign prostatic hyperplasia, or in general called as benign prostatic enlargement. It is suitable for the glands up to 100 cc, but if someone is interested into the guidelines, European guidelines allows up to 70 cc, NICE guidelines and AUA guidelines allows up to 80 cc. But in my practice, I've used even up to 110 or 120 cc's in specific scenarios, and it works. But if any patient maximum 70 cc or 60 cc, the outcome is very good. I will say maybe in the initial stages, it's nice to start with smaller size prostates and plan for larger prostates once your technically quite confident. Urinary infection is a contraindication because we are going to keep an implant into the bladder. So it's very important that we should make sure that the urine is sterile. This video will give you a kind of idea.
Minimally invasive technology designed to relieve urinary symptoms and improve quality of life with minimal side effects for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. The UroLift system procedure begins by inserting an implant delivery device into the urethra. An attached endoscope provides visibility to the obstructive prostate. On reaching the area blocked by the enlarged prostate, the obstructive prostate tissue is moved aside. Following a trigger press, the device inserts a fine 19-gauge hollow needle across the prostate and deploys the implant through the needle. The implant is a nylon suture fixed in place with a thin metal tab at each end. Depending on the prostate size and blockage severity, the doctor inserts several more implants the same way. Typically, 4 to 6 implants are placed into the prostate. The outer capsule of the prostate is firm and provides a solid anchor, which allows the implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. As the sutures are shorter than the prostate depth, the prostate laterally compresses. This reduces pressure on the urethra and provides immediate visible results so urine can flow freely. It's a mechanical solution to a mechanical problem. The minimally invasive procedure requires no cutting, heating, or tissue removal. This procedure avoids erectile and ejaculatory dysfunction. It typically also means minimal downtime, mild to moderate side effects, and a quick return to normal activity. The UroLift system provides a clinically proven treatment for those who suffer from an enlarged prostate that can get men off BPH medications and avoid major surgery.
So as you can see, of course, always this kind of line diagrams or computer animations will be very clear and very beautiful to look at, but we need to extrapolate and we need to mimic and apply this in the real practice. Let us see how we can proceed.
Minimally invasive.
So how will you select a patient? Patient selection, as I said, any patient with difficulty in passing urine, predominantly the voiding symptoms, and those who have tried the medications, but medications were not working. Those who don't want to have the classical TURP procedures are very suitable. As I said, there are AUA guidelines, and AUA guidelines specifically mentions that this treatment, specifically UroLift, is very good in maintaining the erection and ejaculatory function. I have come across some unfortunate men in late 40s and early 50s, not yet completed the family, willing to have at least one more child, or maybe willing to have the first child, where they have problems in passing urine, not responding well to the medications. The UroLift is the only solution which will maintain the ejaculation almost 100%. Now, with the evolvement of technique, even the other technologies like Resume, green light laser, even holmium laser enucleation, there is an adaptation of technique to maintain the ejaculation by preserving the tissues around the veru, which we can see later. As I said, EAU guidelines accepts UroLift for prostate more than 70 cc. And this is an important slide for those who want to understand why UroLift is important. As you can see, this is the healthy bladder, and as the obstruction proceeds, bladder worsens. You may have seen all these findings in the flexible cystoscopy clinic. And at one point, the bladder goes for the irreversible changes or permanent damage. We should not have this happen. It's nice to see the patients at the early stage and give a treatment so that the bladder should recover back to its previous normal mucosa. I will equate if a patient has got these kind of irreversible changes as a metastasis equivalent to cancer. For example, prostate cancer metastasizing into the lymph nodes or bones. So similarly, this benign prostate has caused the distal lesions in the bladder. This is not a good sign. These patients, even after TURP or any procedure, will still have some problems, especially the storage symptoms. So UroLift gives a very rapid recovery, durable symptom relief. It's a good alternative for medical treatment. Those who are responding to medication but not happy with the side effects, this is a good choice. Preserves sexual function and avoids complications of TURP surgery. The whole procedure can be done as a 20 minutes, 15 minutes procedure, and it's a day procedure. We call it as ambulatory procedure, which means patients will walk in, have the procedure, and walk out maybe within an hour or two. This is the graph which shows the historical lift study, which is the major study done, which shows there is a IPSS score fall within the second month, and then the fall is maintained up to long term. And this is our own data, where our data also shows that there is a good fall in the IPSS score. The AUI score also showing a good fall. There are various studies: lift randomized study, BPE 6 study, local IDE study, multi-center prospective studies, and real-world study, including the Australian studies. If you can see, all the studies gives almost the same finding of rapid improvement and durable outcome. How this works? You have seen that it is a kind of an implant, and so this is a canine model. The implant is applied on the inner side of the urethra, and the stainless steel clip will be in the outer side. You can see that it creates the local compression, and the compression creates an apoptosis. There is ischemia and atrophy, which opens up the cavity, and this ischemia or the cavity which is opened is present for long term. We need to do a flexible cystoscopy or ultrasound to make sure we are aware of patient's median lobe. If there is a median lobe, there is a specific technique to it. I will try to show that by using a video. So document the presence of intravesical extension of the prostate, nicely plan the procedure, explain the details to the patient so that the patient will understand what's happening. Now we will look into the components of the implant. So the implant contains a suture, which is a PET suture, and there is a urethral end place, which is 8 millimeter, and the capsular tab is made up of nitinol. The total length of the capsular tab is 13 millimeters. So this is how the handpiece works. The handpiece has got some switches. As you can see, the first switch we need to release is the safety lock, and then releasing the switch 2 will cause the needle to go through the prostate. Releasing the switch 3 will result in the retraction of the needle. And finally, when you release the switch 4, the implant will be finally placed. This animation will explain that. So first we need to unlock the safety key. After unlocking the safety key, once we press the blue switch, you will get the needle inside. And then when you retract the blue and gray, the needle will go back and the capsular tab will be fixed to the capsule. And finally, when you release the urethral tab, the urethral tab will be released and the whole prostate will get nicely compressed. So this animation will explain to you how the UroLift clip is getting deployed. So our sequence and plan is to deploy it in the anterior half of the prostate. It should be 1/3 from the top. There is no way we can employ it in the posterior half because of the neurovascular bundles at the region of 4 o'clock and 7 o'clock. So first we will treat the proximal prostate. Usually it requires 2 implants, and then we'll treat the distal prostate. Usually the 4 implants will be more than enough in most of the patients, but sometimes if there is any protruding tissue, patient may require another pair in the middle. And then if there is any median lobe, we can treat the median lobe also by using a separate implant. I will show this in detail with a video. So these are all the steps. First, we have to get into the bladder and nicely position ourselves. For example, this position, we are treating our right side first. So the scope will be taken out. It should be 1.5 centimeter from the bladder neck, and the first implant will be shoot after compressing the prostate. That's very important. As you compress the prostate, it gives a very nice opened up prostatic cavity. As you can see, the first implant is done, and then the implant scope will be taken inside, and then we will do the second implant on the opposite side. So the same cycle will be repeated. We need to make sure that the implants are nicely implanted, and there will be a small hole through which you can see a white line, which shows that the implant is ready for the placement. This video is very good one. This will show you the real-time picture. This is an old video. We are doing it like with plastic gown and drape, but nowadays we do a full gowning, so the sterile equipments will cover the hands completely. So we are just coming out, treating the right side. We are giving good compression. You can see the cystoscope finding and also how the hand is moving to give a nice compression. And once we give the nice compression, it should be the anterior 1/3 of the prostate. First, the blue trigger will be pressed, which releases the needle. And then slowly we are giving the blue and gray trigger. And you can see a white line there. I will try to magnify it and show you that. Once you see the white line, we can release the implant in the backside. So that's the implant will be released. This is one example. I have another video also to show you much more better median lobe, etc. So we need to make sure that we are nicely bending and creating at least 20 to 40 degrees of bend so that the needle is nicely placed and the prostate is nicely opened up. Regarding the anesthesia, it can be done under local anesthesia. I purposefully showed this slide with these striked off things. Previously, historically, 3 to 4 years back, we used to give 10 milligram diazepam. We used to empty the bladder with a catheter, and we also placed some lignocaine inside the bladder with a catheter. Nowadays, we are not following this. We ask the patient to empty the bladder himself, and then we use 20 ml of lignocaine kept in the fridge at 4 degrees Celsius. This is the whole setup where all the nice wide UroLift boxes will be kept ready. Patient will be in the position. I do this procedure completely under local anesthesia. So there will be a nurse in the patient's head talking to the patient. I can see the monitor. Patient can also appreciate what I'm doing by looking into the monitor. So if someone is interested to start the UroLift, we have an online education program. So for example, if Professor Hamad Akhtar wishes to register his Aga Khan University Hospital into this program, we will give the online education so that the doctors, maybe 3 or 4 doctors, can get trained at the same time. Once they finish the online education, I'm quite happy to travel to Pakistan to teach the procedural training, or I'm quite happy to invite the senior people to my unit in Birmingham so that they can observe what I'm doing. We do these workshops almost every second month. For example, there is a workshop happening 3rd week of March this month and also 3rd week of May. So please inform Professor Hamad Akhtar if somebody is interested. I'm quite happy to conduct some programs. And once you have a nice procedural mastery, then we can teach the advanced techniques of the median lobe. So this is a good procedure showing the median lobe also. So first, we are seeing the cystoscope, which shows the clear obstructed median lobe. And then we will show how the real-time normal lateral lobes are done, and then we will go for the median lobe. So here you can see that this particular procedure, we are doing the left side first, our left side first. And as we come outside, we'll decide the best position to fire the implant. And first the blue and the gray one are pressed. And then you can see the white line there. And then the release one is done. So that makes the first implant open. Now we are doing the right side. You can see that the implant nicely opening up the left side of ourselves, and then now we are doing the right side. Whenever I'm saying the sides, I'm saying our side, it will be exactly opposite side for the patient. So on the right side, again, you can see that the doctor is nicely pressing the prostate. That's very important. And then with the blue and the gray, they will be firing the needle. And once we see the white line, you can see the white line there, they will use the release to place the implant. You can see how nicely, like somebody holding the finger, the implants are opening up both the lateral lobes. And then we need to treat the median lobe. So treating the median lobe, as you can see that we have to give some pressure and make sure that the median lobe implant also goes horizontally. We can't do the median lobe implant straight down because there may be rectum behind, so we don't want to have any injuries of the rectum. And again, we can't do the 4 o'clock and 7 o'clock because of the vasculature. So again, the median lobe also will be treated in the same horizontal panel. Maybe unlike the lateral lobe, it will be slightly at the lower level, but the procedure is almost the same. You can see that the compression is very important. Once we nicely compressed it, and once the implant is placed at appropriate position, you will get a very nice opening, which you will be appreciating in the next few minutes. So once we are comfortable, we will fire by using the blue and the gray trigger points, and then use the release fourth switch to release the one. You can see that how nicely the median lobe is compressed and shifted away. So final result, we have not done the posterior one, but you can see that anterior 2 clips and the median lobes were nicely opened up. The whole thing is almost looking like a TUR cavity, even though we are not using any current or any energy sources. So this is how our outcome should be. For example, if there is a median lobe, nicely do the lateral lobes, and then once you compress the median lobe, you should get a nice opening. Similarly, we can create the lateral lobes first and then use the median lobe to create a nice opening. This is a nice gland. The advantage of this gland is this median lobe is nicely pliable and movable. That's why after placing the lateral lobe implants, the median lobe is nicely protruded and we are able to compress it to create a nice big cavity. Creating the cavity is so instantaneous. Patient should be able to pass urine directly, and the need for catheter is very, very rare. So we have gone through the indications and how we have to select the patient, what are all the components of UroLift, how the anesthesia works, and how the obstructive median lobe is working. So that's all from the UroLift. So I'm happy to take any questions before I go to the next 2 energy sources. Maybe 1 or 2.
Thank you very much. I think that's a beautiful demonstration of the technique and the principle of UroLift. There is one question about the durability of this procedure. We know that TURP is a gold standard, and typically you counsel patient saying that about 10% would require another procedure in about 10 years' time. So how long is the reported literature on the durability of this procedure, and is there a possibility of redo in UroLift cases?
Yeah, very important question, because end of the day, patients are spending the money, or whether through the insurance or not, we should tell them the exact durability. The UroLift literature is now available quite strong for 5 to 7 years. So we don't have the 10-year results. So we don't know what will be the PRP equivalent numbers in 10 years time. But as of now, durability is very good. I will quote the latest studies, which says that the chances of retreatment is around 12 to 13% in 7 years time. So if you see, the numbers are slightly worse when compared to TURP. TURP, as Professor said, is 10% in 10 years, while for UroLift, it is like 12% in 7 years. But this data is because we're all in a very early stage and we're all learning. For example, I've done hundreds of patients. When I compare my first 50 patients and the last 50 patients, I can vouch that the improvement in the last 50 patients is much better. So it's all with learning curve. So with learning curve, I'm very sure maybe in 10 to 15 years time, the UroLift will reach an outcome equivalent to TURP. The one disadvantage is the best outcomes for patients with less than 80 cc. Once it reaches 80 to 100 cc, the outcome is not that brilliant. But TURP, as you know, we can comfortably do even up to 120 cc. Many of us have done even 200-gram prostate, maybe one side at a time, and then bring the patient for the other side at a later time. So TURP will be still the gold standard. There is no doubt in that.
Another question for you, this is about the implant migration. Is there a possibility that you may misfire, or there is a migration once you have appropriately placed that implant?
Migration is impossible because the implants are nicely holded by the capsular tab and the urethral tab. So if at all, if there is any problems, it is only during the implant placement. Once we keep the implant in correct place, the migration is not reported yet, and I think it's feasible at all, not feasible at all. So when you're placing the implant, we need to make sure, as I said, if there is a prostate, the implant should be in the anterior 1/3 plane, and we have to be 1.5 centimeters from the bladder neck, because any implant which is touching the bladder will be constantly exposed to urine. That's where the incrustation and stone formation is possible. We should be 1.5 centimeters from the bladder neck, and then the implant should be in the anterior half. The outcome will be very nice. The channel will be very good.
Linda, there's another question about the number of implants that you can do. Is there a max for what you can do for larger prostate or longer prostates in which you're not happy with 2 implants or maybe even 3 implants on either sides?
Yes. Number of implants is entirely depending upon the length of the prostate, because the width of the prostate is not very important. If the prostate is a bit stouter but shorter, still we can do it just with 2 implants itself. Number of implants are very important because the implant is the most costliest thing in the whole procedure. If you're able to create a good channel with less implant, that's the winning formula. In my hands, the implant ratio is 2.7, which means the total number of implants I've used for all the patients divided by number of patients which I have operated, it is 2.7. That is a good ratio. So a lot of times, many patients require just 2 implants left and right, which we do it in the midway through the bladder neck to Veru. Many patients require 4 implants. I've never used more than 4 implants in general. Maybe very rarely we may come across a patient where the left lobe is very big, right lobe is small, right lobe will require only 1 implant, but left lobe may require like 2 implants. So this is for the lateral lobes. Regarding the median lobe, there are 2 techniques. I don't want to get into the details of it. If you use the old technique, you will need 2 implants. There is a new technique which I'm following now where you need only 1 implant. But I will really love to show these techniques maybe in person when we visit Pakistan, or people can visit us also.
Thanks. There's just one more question about the cost. I'm sure that NHS or private patients would have totally different, and you may and cost in UK may be different from cost in Pakistan. Yeah. The second question about whether your device is reusable or is it also disposable?
Yeah. As of now, the device which I showed you, the device applicator is disposable. But we are now working on a new system where that whole system, we can, the whole applicable device, we can load the applicator, load the implant. It's known as a multi-fire equipment. It is under trial in America now. I will be starting the trial maybe like June or July this year, and I will certainly share the information. Regarding the implant cost, it is approximately 400 pounds in UK. The price is very different in different parts of the country. In US, it's entirely different. So you can't just like that multiply 1 pound is equal to so much Pakistan rupees, and so we can multiply the 400. You can't do that max like that. When the system is getting introduced into Pakistan, I'm very sure that the Teleflex team in Pakistan will do a proper study, and I'm very sure it will be available at much more cheaper rate when compared to UK. In UK, the main advantage is this whole UroLift procedure, as I said, can be done in a 2-hour frame. Patient will walk in, have the procedure, patient will walk out. While in TURP, patient will stay for 1 night, if not the second night. Stay in the hospital, the bed cost is very high in UK. So every night when patient stays, that itself will take easily like 800 pounds, 900 pounds. By removing this night stay, we are spending that money in the implant. That's how the UroLift is a very economically viable option when compared to TURP in UK.
Great. Thank you. I think, Ananda, you have beautifully demonstrated and you have clarified a lot of concepts. And I'm sure people will be very keen to take on the courses that you very kindly offered, and will coordinate with you with all those who are interested. So you can proceed on with your rest of the presentation.
Thank you. So as I said, I'm going to show you 2 more devices. I will show you one device by name iTind, because it's a very short one, just a video, just to give you an idea on how it works. The another one, Resume, it's well popularized at present, and it's now popularized in UK, America, various parts of the American countries, UK, and also in European countries. So I will go to the Resume as a third one. Are you able to see the screen? Meditate?
Yes. Yes.
It's a video.
The iTind is a safe, quick, and minimally invasive procedure for the treatment of benign prostatic hyperplasia by using a temporarily implanted cutting device. First, a rigid cystoscope is inserted into the meatus and guided up the urethra until it passes the bladder neck. The iTind device is inserted into the sheath in a crimped configuration and pushed through until it is released into the bladder. The cystoscope sheath is withdrawn, the optics are reinserted, and the cystoscope sheath and optics are guided back in parallel to the iTind delivery system for visualization. The iTind device is manipulated to bring the anchoring leaflet into the 6 o'clock position and distal to the bladder neck. The cystoscope is removed. The guide wire is cut at its proximal end and removed, exposing the retrieval suture and leaving the iTind in place, where it will remain for only 5 to 7 days. During this time, the 3 cutting struts of the iTind device expand and exert pressure on the prostatic urethra and bladder neck. This gradual and continuous pressure creates 3 deep longitudinal incisions through ischemia and necrosis at 12, 5, and 7 o'clock. After 5 to 7 days, the iTind device is removed. First, the retrieval suture is threaded through an open-ended silicone Foley catheter. The catheter is advanced until it meets the iTind. Once reaching the device, the retrieval suture is pulled taut and the iTind device is easily collapsed into the catheter and removed through the urethra. Once the device is removed, deep incisions and an open pathway through the prostatic urethra can be observed. The procedure is now finished.
So again, I wish to show this procedure because it is nice to know that there are some.
All right, I'm going to get into the next topic.
It is nice to know that there are some techniques which are in the very early stage, because this particular technique is not that popularized yet, because we need to do some randomized study. We need to do plenty of groundwork before it is available widely in America, UK, and also in the Asian countries. But I wish to give you a flavor that this principle of creating a nice open channel just by compression is very much here. Like iTind, there are multiple clip-like devices which are in the trial also. So I just want to show this as a trial, but I will go ahead with the presentation on resume, which is much more important. So resume is now very well established. There are multiple studies, thousands of patients, randomized studies. There are even randomized studies comparing resume with the UroLift. Resume works by the principle of convective radiofrequency waves. For those seniors, they may heard about some energy sources like transurethral needle ablation, which were now out of practice in America. The reason why the transurethral needle ablation failed is because it used the conductive method to pass the energy and heat source, while resume works by convective radiofrequency, because of which the chances of tissue damage and chances of capsular injury, chances of sphincter injury are much, much less. The energy transfer happens by using a needle. By the needle, we pass the water vapor into the prostate, which causes convective changes and apoptosis. And I will demonstrate this by using an animation and also a video. So as I said previously, the energy transfer by radiation and conduction, that's the reason for all the side effects. But since resume uses the convection, it is scoring much better. So this is how the machine works. There is a generator. Normal saline will get into the generator, getting heated up, and the heated normal saline will get injected into the prostate by using the needle here. So this is the handpiece, and this is the switch to switch on the needle, and this is the switch so that we can now inject the water vapor. So this is from a different angle. Why water vapor is used? So water vapor disperses quite rapidly between the cells. It's a very gentle and efficient transfer of the energy. It immediately causes the cell membranes to collapse, and collapsed cells absorbed by apoptosis. Each treatment is using only 0.5 ml of the water, sterile water, and it lasts around 9 seconds. And it's very good for treating any shape and size of the prostate, including the median lobe. So this is how it looks. In 1 week after the treatment, you can see that there is a hypoechoic area where the water vapor is working. And 3 months afterwards, the complete transition zone is collapsed. You can see the whole prostate is collapsed. It has got only the peripheral zone only. So our aim is to produce contiguous water vapor injection, maybe 3 or 4 on each side, so that they are touching each other, creating a nice apoptotic prostatic cavity in long run. So how the resume works? The main thing is the areas where we inject the resume, the alpha-adrenergic nerves, which we are blocking by using, say, tamsulosin, they're all burnt out. Smooth muscle tissues are opened up, and vasculature is also reduced. Since the vasculature is reduced, the bleeding is less, and chances of regrowth of prostate is also quite less. As I said, both UroLift and resume are now well accepted by the NICE guidelines, AUA guidelines, and EAU guidelines. Let us learn this with the help of a video. So we will pass the scope, and then with the help of the first switch, we will inject the needle. The needle has got multiple holes, which releases the water vapor. As you can see, the water vapor with the temperature, high temperature, really coalesces all the tissues, making a nice compression of the cells. It's very important that it lasts for 9 seconds so that the apoptosis will happen later. So this is the real patient appearance. It may be slightly not very comfortable to understand initially, but once you started doing it regularly, the vision and anatomy will be very easy to understand. So cystoscopy has to be done very carefully because we have this needle applicator in the tip, which can cause significant damage if the equipment is not kept exactly in the lumen. And once we are inside the lumen, we can decide how many times to inject. Again, all injections will happen only in the lateral plane. We should not inject in the lower plane to prevent injury to the rectum. Here you can see that we are coming back from the bladder neck, and this is the needle which is injecting the steam now. You won't see a big channel happening straight away in front of your eyes like UroLift. This only produces injection of the water vapor. In fact, after the procedure, sometimes you may feel that the prostate is more obstructive because of the swollen prostatic tissues. That's why patients undergoing resume should have catheter at least for 3 days. It is very important. If we are not placing the catheter, patient will fail to pass urine, and placing a catheter on a later date will be more challenging. So it is always better to keep the patient on a catheter immediately after the procedure. That's one of the main disadvantages of the resume. So here you can see that we have done 2 injections. After the first, every injection, automatically after 9 seconds, the treatment will automatically stop. So you will never mistakenly give a large dose of water vapor in one particular area. So it is 9 seconds, you can give multiple injections, and that's how the resume works. It's a nice procedure. Immediately you won't see a good cavity, but in long run, you will see that patients are having very nice cavity and very nice outcome. Multiple literatures, multiple studies, pilot studies, water 1 study, water 2 studies, multiple studies are available to support the literature. Since you can't appreciate the procedure well, I will show you by using an animation. You see, this is one animation which shows quite clearly how the opening happens. So we have these highly vascular prostatic tissues, which are quite succumbent to the water vapor. So apoptosis and immediate cell death are the main principles. Again, denervation of nerves and receptors happens. The denervation is almost as similar to the alpha blockers. The treated tissue will be slowly absorbed, resulting in the opening of the channel. And for example, this is one of the patient's 3D MRI rendering. After 1 week, you can see that the tissues are nicely responding. After 1 month, there is a nice collapsing of the transition zone, and transition zone almost disappears in 6 months' time. Now we will see the actual procedure. Again, this was recorded at a very early stage. So nowadays we have much more sterile settings. So this is the water which is getting heated, and then once we get in, the doctor was able to keep the injection on the left side and right side. We can do multiple injections. It's the same hand piece, and patient is only under local anesthesia. You can see he's moving his hands. And these 2 procedures, UroLift and resume, can be done completely in outpatient setting. It is quite difficult to demonstrate the resume procedure as clearly like UroLift, but you can appreciate that the needle will come out from the tip, and by using the 2 switches, one to release the needle and one to release the water vapor, we are injecting the water vapor into the prostatic tissue. As I said repeatedly, immediately after the injection, you won't see a big cavity like UroLift, but once you keep a catheter for 3 days, patients will be having good successful removal of the catheter. In long run, if you have to do a follow-up flexible cystoscopy, you will see a nice opened up channel. Thank you very much. I'm happy to answer any questions on resume or iTind.
Great. Thank you very much again, Ananda. I have a few questions in the chat box. This question about chances of hematuria or bleeding following resume procedure.
Yeah, again, we are using a needle. So we are piercing the prostatic mucosa with the needle. So there will be a possibility of bleeding. But as I said, all the resume patients, 100% will require catheter. So since there is a catheter, if there is a small amount of bleeding, the catheter will take care. But the bleeding as such for UroLift and resume are very minimal when compared to the TURP surgery. None of the patients will require like a 3-way catheter, irrigation, or sometimes need to take the patient back to the theater to get hemostasis. Those things are almost non-existent.
Great. There's a question about retrograde ejaculation. How would you compare this with the UroLift?
Yeah, again, the concept of retrograde ejaculation is now changing. If I have to quote the historical concept, the belief is when you destroy the bladder neck during the TURP, it results in retrograde ejaculation. That concept is now proven completely wrong. The retrograde ejaculation is due to injury to the veru, and not really the veru, the ejaculatory duct, which is opening in the veru. So if you are able to manage a collar of tissue around the veru, that prevents injury to the ejaculatory duct, and patients will still preserve antegrade ejaculation. This principle is used in all the procedures now. HoLEP, there is a ejaculation preserving HoLEP, there is ejaculation preserving green light laser. In resume and UroLift, we are not even going closer to the veru. We are staying quite on the top. As I said, 1/3 from the roof, 2/3 from the bottom. So the chances of retrograde ejaculation should be non-existent.
Right. Question about painful ejaculation or hemospermia. Have you seen any of the patients complaining of these two things in your clinical practice and the world experience?
Yeah, again, both UroLift and resume should not cause any major problems in erection and ejaculation because we are quite away from the ejaculatory duct. Purposefully, the injection should stop as we come closer to the veru, or if there is too much of tissue closer to the veru, the resume can be given more in the anterior region rather than closer to the floor. So erection problems, ejaculation problems should never happen. But on the corollary, compared to UroLift, resume can cause a kind of dysuria, which we need to warn the patient. Patient will have a burning sensation while passing urine because it takes some weeks for the water vapor to resolve the prostatic tissue. During the resolving period, patient will have dysuria, but simple anti-inflammatories, paracetamol, ibuprofen is more than enough.
Great. I mean, nearly 30 years in urology, and I've seen everything being done to the poor prostate, microwave thermotherapy, needle ablation, and then we had HIFU and so on. So how do you see these new generation minimally invasive interventional procedures compared to the ones that we used to have in the past? Because they came and there was initial enthusiasm and then they fade away.
Yeah. Absolutely important question, because especially for the young urologist who is trying to learn, trying to get the best out of possible treatment for the patient, they will be traveling a lot. I've seen patients or the physicians from various Asian countries traveling all the way to Birmingham to see what I'm doing. And so after spending so much of money, learning the technique, and then if the outcome is not good, especially if it's not a durable outcome, the whole thing is like a waste of time, and whole thing may look like the gimmicks of the pharmacy industry. I will be quite vocal on that. Even though that concept is there, I will have a very good, strong belief in these two energy sources, UroLift and Resume. That's why in my whole presentation, I took enough time to explain these two compared to iTind, or there are multiple similar clip or the opening of the prostatic cavity based minimally invasive procedures available. Plenty, around 5 to 6 available. I don't want to even mention them, but iTind is now recognized by the NICE guidelines. That's why I want the trainees to know about that. UroLift and Resume, I think, will have a place to stay for long term. The only issue possibly with UroLift is the cost, but it's entirely financial one. So if there is a good insurance backup, if there is a good government backup, UroLift giving very good outcome. As long as we select the patients appropriately, the surgeons should do a non-median lobe, just lateral lobe patients, maybe for 20 patients, and then start doing the median lobe, keep the glands less than 70 cc. And once you have done maybe 50 or 100 patients, you can do up to 100 or 110 cc. So slowly improve the complexity, the outcome will be very good. And maintain a logbook, maintain the strict follow-up so that you will know what is happening. We don't want to abandon the procedure just because 1 or 2 failed out of 100. At the same time, we should not take for granted that nobody is coming back to me, so all the procedures are good. In UK, we have a very strict audit protocol, so we need to maintain that so that we can present the data in the national and international meeting. Resume, even though by technique it mimics like the transurethral needle ablation, which is now faded away. As I mentioned, the main importance is the convective radiofrequency energy transfer. The method of the convective energy transfer is much more prostate tissue friendly. It will not cause the necrotic ablation. It should cause ischemic apoptosis. Ischemia is fine. Apoptosis is good, so that the tissues will disappear. But necrosis is quite bad. Necrosis is the one where the patient end up having multiple follow-ups, strictures, and secondary stone formations, etc. So since Resume uses the convective principle, and it's a nice topic, I'm happy if any of the trainees wish to learn about these 3 methods of energy transfer: radiation, conduction, and convection, and how convection is much more safer compared to the other 2, so that you will have more confidence in the Resume. Whether countries of Asian origin, whether we are following this, whether we are introducing this or not, I'm very sure that America, Australia, New Zealand, UK, European countries have nicely jumped into it. If you are following the AUA meetings or World Congress of Urology meetings, there will be multiple presentations on this. So I don't want people from the Asian countries to be left out. So that's the main reason I selected this topic when I was asked to talk. I was not asked to talk any specific topic. I choose the topic so that it will be a nice introduction to the people from Pakistan. And I've got a lot of colleagues, Pakistan colleagues working in UK performing this procedure. So we have a very good team. We are quite happy to come and demonstrate and take it in a very slow learning process so that the procedure is nicely learned and established.
Thank you very much again, Ananda. I think that's a very kind offer, and we would definitely take advantage of this. Thank you from the team here for being available for all of our academic activities. And I hope that we will be able to engage you again soon on a related subject of your choice. So next course, which is on the third Saturday of March. I don't know if you know Sarfaraz Ahmed. He was working in Glasgow as a consultant until 2018. So Sarfaraz has since moved to UAE, and he's working there as an associate professor. He did his CCST higher training in urology in 2015, and he worked as a consultant in 2018 when he moved to UAE. So Sarfaraz is going to talk about the screening and principles of radical prostatectomy. Again, an important subject for our trainees to know, and hope that you will be able to join us again. With this, I thank again Mr. Ananda Kumar for his wonderful in a very educative talk on these minimally invasive procedure. And have a very good evening to all of you. Take care.
Thank you very much.
Bye.
Thank you for the opportunity. I will be quite happy to talk on a different topic on a different month. Thank you very much.
Great. Thanks.